Hello, everybody in Psych XB1. I apologize for having to present our last class in this particular format, but I guess we can't really do a lot about it with classes canceled. I also apologize if there's any distractions going on in the background while I'm presenting. Unfortunately, not only is school canceled for us, but it's also canceled for my kids, which means I've got not only recording duties, but childcare duties as well today. So I'm going to try to kind of avoid those distractions as much as possible, but I might need to step away for just a second or two as we're going through these recordings. But we do have a lot to get to. It's our very last class, and it really is going to round out the topic that we've been discussing for the past, well, three classes before this, and then this one of clinical psychology. So let's get started in on the material, and hopefully you can get just as much out of this as you would get out of any lecture that we've had so far in class. So obviously in our last class, we spent a lot of time talking about specific disorders, and we actually focused our attention in that class on a grouping of disorders called anxiety disorders. We also, though, closed out the class by talking about another grouping of disorders called mood disorders, and in it we just focused our attention on one particular mood disorder, actually the most prominent disorder that we diagnose in the United States, called depression. And we talked about the symptoms, the treatments, the different causes, other things linked to it that we know about since this disorder was first diagnosed a number of decades ago. What we're going to be doing in the first part of today's class is just kind of expanding on this topic of mood disorders, looking at other ones that fit into this category, and most importantly, really differentiating them from depression, which is something that often is done when talking about the different mood disorders that exist. And we're going to start when talking about these mood disorders with one that's not necessarily really prominent in California, but it is really prominent in other parts of the United States and around the globe. This particular disorder that we're going to be talking about is something called seasonal affective disorder, which is something, as the name kind of implies, that's very closely linked to the seasons. Now, in our southern states like California, Florida, Texas, this is a very rarely diagnosed disorder, but if you start going up to our northern states like Minnesota, North and South Dakota, Wisconsin, and even further like Alaska, or work your way into Canada, what you see is this particular disorder becomes significantly more prominent. And the same can be said for places in the lower portions of the globe as well. And when you look at this particular disorder on the surface, it looks like depression. You see all the cognitive symptoms, all the affect symptoms that would scream to a clinician that this is depression. But what's really critical with this disorder, that tells us, first of all, that it's probably distinct from depression, is that this comes in waves. So what you see for most people diagnosed with seasonal affective disorder is that their patterns of emotion kind of follow like you see here in the chart, where in the summer months, everything's great. They report fairly good levels of affect. They don't feel like they have any problems or major mental health issues. But then as we start to go into the winter months, as fall starts to kick in and winter really takes hold, these individuals start to report symptoms and feelings that are indicative of depression. And we don't see this fluctuation in depression, which is the first big sign that we're looking at something that is unique, that's something that's different from depression. But what really tells clinicians that this is a very unique thing from depression is the fact that there is a really robust treatment for this that doesn't really work for depression, and it's something called light therapy. Light therapy is essentially a means of exposing individuals to specific types of UV light. It's kind of a spectrum of different things. And for people struggling with seasonal affective disorder, when they're exposed to this light for an extended period of time, usually it's like an hour or two every day, they report a huge amount of abatement of their symptoms. They essentially start to feel more what they would call normal within a few days or weeks of going through this specific type of treatment. And this does not really work for individuals who are diagnosed with the typical cases of depression. So the fact that you've got these fluctuations related to the seasons, you've got this type of therapy that really works well for it versus what we see for depression, we know in clinical psychology that we're looking at something that's distinct, unique from depression, even if the symptoms look very similar. This is somewhat true also for the other type of disorder that's listed here on the slides, called persistent depressive disorder. Now, historically, it was also called dysthymia, if you're looking for stuff in kind of past clinical books. But this one, again, looks a lot like depression on the surface. It's got a lot of the cognitions and the emotional issues that we saw with depression. But again, what makes it unique is that there's kind of causes to it and treatments to it and nuances to it that are very different from depression. So this one, as the name kind of implies, is significantly more persistent than depression. Most people diagnosed with depression will have symptoms that last for 6 months, maybe a year. For PDD, you have to have these symptoms for at least 2 years to even be diagnosed with it as an adult. And for kids and adolescents, they need to have symptoms related to it for at least a year before they can even be diagnosed with it. And most people who are diagnosed have actually had these symptoms for much longer than that. The symptoms are usually considered significantly milder, even though there are some cases where that's not quite the case, where these people have essentially major depression for years on end. But the fact that most people struggling with it have slightly milder symptoms, but much more persistent symptoms, has been a big cause for concern for many clinicians, because there's this notion that for a lot of individuals struggling with it, it might start to just become assumed that this is more of a part of who they are than a specific disorder that merits treatment or assessment and some type of intervention. Uh, it, the, there are some individuals that argue that a lot of times what's going to happen for people diagnosed with PDD, or actually undiagnosed with PDD, is that they're going to just start to be categorized by individuals as just these grumpy, sad individuals that aren't very fun to be around. And this can start to eat away at their social life. This can start to eat away at their ability to function in their jobs and other aspects of their kind of lives. And it can really have a detrimental effect on these individuals. This is why there's a lot of people studying this that have argued that, one, this is probably an undiagnosed disorder, because people just start to assume that this is more a part of people than it is a specific disorder. And two, this actually might have more of a negative lifelong impact on these individuals because it does last for so long, and it can be overlooked by lots of individuals, or just I guess, categorized as part of the person, not a disorder that is kind of something that hopefully can have some type of positive treatment linked to it. So if we're looking at PDD, again, we're seeing something that's very similar to depression, but it's unique in this case in terms of how long it lasts and kind of the severity of the symptoms that we often see for individuals who are diagnosed with this. So we've got two fairly similar disorders linked to depression that have their own unique things here listed in the slides. The last affective disorder or mood disorder category that we're going to look at, or type that we're going to look at, is one that's very unique in comparison to all the rest of them. It's sometimes referred to as manic depressive disorder, even though you'll see it listed in the literature as bipolar disorder. And this is one that does usually have negative affect linked to it. But the thing that makes this disorder, which is, by the way, very rare, it's something that's usually linked to genetics and not gender or age or anything else. It's more of a biological thing that we think is going on. The one that makes this very rare disorder unique is these things that we call manic symptoms that are a part of it. Some people might have relatively mild manic symptoms. Many individuals have very profound ones, and they come in a variety of forms where people are sometimes extremely agitated or very excited, or just kind of flighty in their thoughts, where they're kind of jumping from thing to thing, and there's no real coherence to it. But when people struggle with bipolar disorder, that's those manic symptoms that really are the main problem for them, at least usually are the main problem for them. It's not, I guess, true for everybody with it. In fact, what we see with bipolar disorder is that to kind of better differentiate between the different types of bipolar disorder that are out there, clinicians have actually come up with names for the different categories of bipolar disorder that they've encountered. So one type that's out there is this thing called bipolar type 1 disorder, where people struggling with this experience what's called one major manic episode, at least one. Usually they actually fluctuate back and forth between what would maybe be considered for them normal mood, negative affects that could be indicative of depression, and then some type of kind of full-blown mania, where they can usually be very destructive towards themselves and others while they're going through these manic episodes. The other type that's out there is one called bipolar type 2, where people are experiencing this thing called hypomania, which is milder versions of manic symptoms. But that doesn't mean that it's a great thing, even if they're encountering this, and they can't be really destructive for these individuals. It's just not quite as full blown as a bipolar type 1 manic episode is. For people diagnosed as having bipolar type 2, they also have to fluctuate back into not just milder depression, but severe depression. Bipolar type 1 doesn't require major depressive episodes. It's usually just kind of the focus on having manic episodes that's really critical here. Now, others who don't go into full-blown mania or full-blown depression could be described as cyclothymic, another category that's out there. And it's really important to note that it's not like clinicians are trying to force somebody into a category. All they're doing is looking at the severity of their symptoms that they're going through in the manic episodes and the depressive episodes, and through that, they're giving somebody a definition so other clinicians can talk about this and think about treatment forms. And when we're talking about treating this particular disorder, we're looking at one of the first ones where treatment has been a real struggle over the years. In the past, there was attempts to use cognitive therapy and behavioral therapy to treat both the manic symptoms and the depressive symptoms. And even though they can sort of work, they're not exceptionally effective because of the fluctuations that people go through when struggling with this disorder. Then we started to come up with antipsychotics and antidepressants that actually seemed to work fairly well. One of the terms that I see is blocked out by my photo right now, these things called mood stabilizers, which usually involve lithium salts and anticonvulsants. And these things kind of, when used at the right times, could really help treat a lot of the manic symptoms and maybe help a little bit with the depressive symptoms. But for a lot of individuals, these drugs were considered miracles, but unfortunately, they were only miracles when they were being taken. And trying to get people to take their drugs when they're in their manic phases is sometimes a huge challenge. So there's been attempts to figure out what the right drug concoction can be to help people not only deal with their manic symptoms, but also the depressive symptoms so they can stay on them. There's also kind of attempts to intervene in ways that we haven't thought of before, where we might be able to kind of inject some type of slow releasing capsule into individuals so they can experience the antipsychotics even when they're going through their manic phases and really help them with some of the problems that they have. But it's a really tough disorder because all the treatments that are out there have their challenges linked to it. And unfortunately for people struggling with this is a profound disorder that really shifts their lives. And very rarely is this something that you just kind of have a bout with and then you're better. Usually this is a persistent lifelong thing. So if we're looking at major disorders that are out there, this one is fortunately very rare, but when it hits you, it's a very profound one, even if it's put into the category with other mood disorders that kind of have this notion of there's kind of an answer to them. And once you kind of catch them, then you can maybe help these people get on the right track. With bipolar disorder, it's a little bit more difficult and a little bit more challenging. And in fact, that's why it's very closely linked actually to the next disorder that we're going to be talking about. But just to kind of close out with this idea of mood disorders, all the ones that we've talked about so far in today's class have been put under the same classification of mood disorders because affect's the big thing with them. And sorry, I'm hearing the baby cry. What we're going to look at in our next category is this other classification of disorders called schizophrenia. And we'll do that in just a second. So just give me 1 second. I'll kind of move on. All right. So this last classification of disorders that we're going to be talking about in class today is very broad. It can actually impact people in a number of different ways. We're going to talk about some of the symptoms that are linked to it. But it's probably first important to talk about the fact that there's been a lot of things that this disorder has been connected to over the years that's very incorrect and actually kind of not tied to this disorder. So one of the things, if you've watched movies or read books that link up, that talk, not link up, but discuss schizophrenia, one of the things that's been often tied to is this thing called multiple personality disorder. Nowadays it's called dissociative identity disorder. People struggling with schizophrenia have issues with cognitive symptoms, emotional symptoms, but they often don't think of themselves as being multiple individuals. That's definitely not a common symptom of schizophrenia. In fact, it's kind of a totally distinct thing, uh, very rare as well. Another thing that schizophrenia is often tied to is sociopathic disorder, where they take pleasure in the pain of others, or antisocial personality disorder, where people really struggle to feel the ability to kind of connect to individuals and can't really empathize with others. None of these things are really hallmarks to schizophrenia. In fact, very rarely are they actually tied to individuals struggling with this disorder. Instead, what we're seeing for people diagnosed with schizophrenia, which is relatively rare, only found in about 1% of the population, very similar to what we saw with bipolar disorder, is just this dramatic disconnect from reality, where they're hearing things or seeing things or experiencing things or having thoughts that are very far from the norm. We're looking for where this one's coming from. What we see is that gender doesn't seem to matter, but this one takes a long time to manifest itself, and when it does, usually you can see biological markers and kind of genetic markers that they're probably the big predictors of who is diagnosed with this specific disorder. In fact, that's one of the places that many people have focused their attention on over the years when talking about schizophrenia is not necessarily all the different symptoms that are there, because it does come in so many different forms, but where this particular disorder that can really destroy the life of an individual is actually coming from. There's been a number of twin studies that have actually shown that genes do matter, but it's really important to note that we haven't found a specific gene or gene combination that's linked to schizophrenia, at least at the point of this recording, we haven't found this. And more importantly, with looking at twin studies, having a twin with schizophrenia is not a definitive thing where you're going to be diagnosed with it. In fact, usually what we see is if you have an identical twin diagnosed with schizophrenia, you get about a 50-50 shot of being diagnosed with it at some point in your life. If you've got two parents diagnosed with schizophrenia, you have about the same 50-50% chance. Uh, it, and this really suggests that genes matter a lot, but it also screams to clinicians and statisticians that there has to be some outlying factor that's also playing a role in the development of this disorder. We're looking for where other things can be tied to the kind of emergence of symptoms. What we've seen is that at the cellular level, it might be kind of tough to figure out who's got schizophrenia and who doesn't when you're looking at the brains of a 12-year-old or a 16-year-old. But as people start to age and their symptoms of schizophrenia get more robust, what we see is shifts in not only the cells in the brain, particularly the hippocampus and parts of the cerebral cortex, but major shifts in the actual structure of the brain. So you can see here a slide that highlights two identical twins, one diagnosed with schizophrenia and one not. The one on the right is the one who was diagnosed with schizophrenia. And you see larger ventricles. If you look down at the cellular level, big tangles in the brain of these individuals. But this stuff is not something that's necessarily prevalent when somebody first starts displaying symptoms of schizophrenia. In fact, it's almost impossible to look at a brain of a 12-year-old and say, yeah, you're going to have symptoms of schizophrenia or not, just because structurally everything looks pretty similar until things start to kind of go awry. Which leads to the question of, is this something that's actually a byproduct of the changing brain, or is the changing brain a byproduct of the different experiences and thoughts that are going on? It's tough to tell. But one of the things that people have started to argue is that, even if it's causing the changes or the changes are causing the structures, there has to be something else that's really triggering. And we have to find the source of why these people are kind of going off on the different track that they're going up. And this has led to something in clinical psych that we call the neurodevelopmental hypothesis of schizophrenia, which it would suggest that it's probably a byproduct of something genetic and the interaction with that, and something that we experience at a very young age. Suggestions that maybe prenatal care, issues with pregnancy, exposures to influenza viruses, lots of things could kind of contribute to each other to kind of put people on the track when they're in a young age to developing symptoms of schizophrenia. But unfortunately, with this neurodevelopmental hypothesis, it's really tough to trace it back to one specific thing, because symptoms of schizophrenia don't emerge until years after maybe some of these triggers might have been encountered. And none of these triggers have proven to be absolute. We're looking at who's going to develop schizophrenia and who's not. This challenge is compounded by the fact that when we look at schizophrenia and what people are really struggling with, it comes in a vast variety of different forms. Again, schizophrenia is usually just diagnosed when somebody's showing a really profound cognitive and behavioral disconnect from reality, but the way they can disconnect from reality happens in a variety of different forms. One of the classic examples of a symptom of schizophrenia that we often talk about are these things called hallucinations. Something that's very closely paired to that is delusions, but there's other symptoms that are very persistent in individuals with schizophrenia or diagnosed with schizophrenia that needs to be taken into account when people in the clinical world are trying to assess whether or not they should give somebody the diagnosis of schizophrenia. They look at disorganized behaviors, incoherent speech, changes in emotional and cognitive responses. It kind of falls under a whole bunch of different categories, which is why when clinicians are trying to diagnose somebody with schizophrenia, they might put them in a specific category, but more often than not, they focus a lot on the specific symptoms that the person is experiencing. And when talking about the symptoms that somebody is struggling with, one of the things that clinicians often do is they categorize the symptoms into different groups. So they'll call symptoms of kind of schizophrenia that are present in individuals diagnosed with schizophrenia that aren't typical in most people's repertoire positive symptoms. They'll talk about the things that these individuals lack in comparison to controls as negative symptoms. And they also look at what's called cognitive and affective symptoms when looking at kind of changes in cognitive abilities and changes in mood that also are common results of the developing symptoms of schizophrenia. Now, if we want to understand positive symptoms more, we can go back to those hallucinations and delusions that we referred to earlier. Usually, when talking about hallucinations, most people encountering schizophrenia experience auditory ones if they're going to have them, so they hear different voices or hear different sounds. But they can actually fit into a number of different categories. So visual hallucinations are also fairly common. There's some people that have tactile hallucinations, some that have olfactory hallucinations. It comes in pretty much every sense that you can imagine. And when we're looking at these hallucinations, for a long time, it was kind of misunderstood that these things were maybe things that these individuals were just kind of bringing up on their own and they could be easily ignored. With some of our brain scan research that we've done in recent decades, what we've been able to verify is that these individuals are oftentimes experiencing these hallucinations because their brain is being activated as if they're actually experiencing a lot of the sensations that they're reporting. It kind of gives us a better sense of why a lot of people struggle to differentiate between what's an imagined voice and what's an actual voice, because their brain is responding to this imagined voice just as it would respond to a typical voice that they're actually hearing. And this makes treating these hallucinations significantly more difficult. The same idea with the delusions. We see with delusions for individuals who are diagnosed with schizophrenia and kind of put in this category of having this positive symptom, so these individuals kind of start to form unfound beliefs, but these beliefs are not just kind of things that are flying by. These are very rigid things that are almost impossible for these people to differentiate from reality. Delusions can happen in a number of forms. The most classic one is what's called the delusion of persecution, where there's this belief that somebody or some entity is somehow conspiring to harm or hinder the individual. The classic one is when people thought that the CIA was spying on them or kind of digging into their life. Nowadays, people will talk about presidents doing horrible things to them or aliens coming down and grabbing them. It can come in a variety of different forms. But if you've got this kind of unfounded belief that some group or some entity is conspiring to get you, usually you would be defined as having a delusion of persecution. This is often also paired with grandiose delusions, where people believe that they have some version of unusual importance, either superpowers or some type of thing that's kind of linked to them. But these can come in a lot of different forms. In fact, if you look at these slides, you'll see that I included an example that actually one of my colleagues ran across when she was a graduate student at Berkeley, where she was interviewing somebody who said that he had the ability to impregnate women just by flicking his fingers at them. So he would just walk down the streets of Berkeley and flick his fingers at any woman that he found attractive, and he was convinced that that was all that was required to kind of send his seed, I guess, all over the world and kind of help him kind of continue his progeny long after he had died. And it was impossible for her to really kind of get any clarity on where this was coming from. and also get him to recognize that this didn't make much sense. And this is very common for individuals who have these types of delusions. It's really tough to break these down, just as tough as it is for them to kind of break down any hallucinations that they're experiencing. Another type of delusion is very common is these things called delusions of reference, where people see messages or ideas in newspapers or other things that they're encountering that aren't actually there. And sometimes there's ones that just don't fit into any of these categories, so they're sometimes defined as what's called bizarre delusions. Another classic example of this was one that another one of my colleagues ran across when he was a graduate student, and he started talking about how he had this client that came in and was really flustered because he was convinced in the night that all of his vital organs kind of left his body. Not that somebody had stolen them, not that there was anything really kind of intentional behind it, but his organs, he was convinced, were gone. And he was really concerned that he was going to drop dead at any moment as a result of this experience or this problem. There are some delusions that kind of fit into this category, not that specific delusion, but these types of delusions that fit in this category where, again, it doesn't quite match up with anything, even though obviously it's a break from reality. So we have to find somewhere to put it, and that's where that fourth category kind of comes into play. These positive symptoms overall are usually the prominent things that we link to schizophrenia, but again, they're not the only things that pop up for people struggling with schizophrenia. The other types of symptoms that kind of counter these positive symptoms are things called negative symptoms. Not that they're kind of balancing them out, but instead what we're looking at with negative symptoms are people's kind of inability when they're diagnosed with schizophrenia to do the typical things that most people do. So one of the things that they usually struggle with is emotional range. There's this thing called anhedonia, which is very commonly diagnosed in individuals with these negative symptoms of schizophrenia. And it's often paired with this thing called blunted affect, where not only are they not feeling a huge range of emotions, but they're often lacking emotions as well in terms of the kind of expression of them on their face or their contact with individuals through kind of conversation. And in fact, this often leads to social withdrawal and the inability to kind of take care of themselves because of these huge diminished emotions. Sometimes this can be paired with emotional issues as well. So depression can often also kind of, oddly enough, be paired with anhedonia. But if we're just looking at it on the surface, anhedonia itself is described as a negative symptom. These positive and negative symptoms also do often pair up with cognitive and affective issues. So with cognitive symptoms, usually we see language issues where people are jumping from topic to topic when they're conversing, and it's not like two people that get super excited to see each other and they're just jumping all over the place. It's literally like mid-sentence, they're jumping all over the place. They also tend to get really easily derailed where they stop thinking about something entirely, or they just have big issues pulling up memories of specific information. And this can oftentimes also be paired with some major affective issues. And these affective issues can come up on their own, but oftentimes the depression, the anxiety is kind of a byproduct, we think, with kind of the cognitive symptoms that are happening to these individuals, the negative symptoms and the positive symptoms that these individuals have. In essence, what I want you to see with all these different categories and symptoms is that when somebody's diagnosed with having schizophrenia, the symptoms they have can actually fall in a multitude of different categories, and oftentimes they interact with each other, and it can be really problematic for people who have this, especially because this is kind of a lifelong thing when people are diagnosed with schizophrenia. Now, technically, there are some rare cases where people have this mental break from reality. They go into a hospital, somehow everything kind of gets fixed, and they go on their way without any really continuation of the symptoms, but that's very rare. Usually, the best case scenario for individuals is that they stay persistently with just milder symptoms of schizophrenia, where they're experiencing maybe hallucinations, delusions on occasion, and things like cognitive behavioral therapy can kind of help these individuals just kind of stave off their problems. But for most people, usually the way to treat these individuals is to try to kind of combine drug interventions with different types of cognitive interventions to kind of help them with the multitude of different problems that they're struggling with. The medical approach has been one that's been very kind of riddled with problems over the years. Antipsychotics have been around for an extended period of time, but a lot of the early antipsychotics that were first introduced produced some really nasty side effects. It produced things like seizures, dystonia where people would kind of be frozen, or tardive dyskinesia where people would have these kind of repetitive motions where their hands or their bodies would lock in a specific thing and just go over and over again. And they'd have these weird things called tongue rolls where their tongue would roll in the front of their mouths. Um, it, it, it the side effects could actually happen in a variety of different forms, and unfortunately, a lot of them persisted even after these people would get off to these antipsychotic drugs. So it had a really rough history when these things were first introduced. But the reason why they were kind of used a lot in the past was they did have pretty profound effects on the different symptoms that people have. And nowadays, we have a variety of different antipsychotic drugs that are applied to individuals. And what usually is the biggest challenge is figuring out which drugs work best for individuals. Because unfortunately, almost all antipsychotic drugs work pretty well immediately for people, but there's still some that produce some side effects for individuals diagnosed with schizophrenia. And for a lot of individuals, the efficacy of these drugs wanes with time. So kind of finding the right combination of drugs is really a big issue for individuals who need treatment for their symptoms of schizophrenia. And in fact, that's one of the big areas of research that's going on with schizophrenia right now is figuring out how to kind of diagnose when somebody's developed schizophrenia so you can figure out a course of action, try to treat them. And then how do you monitor kind of keeping people on drugs and finding the right drug combination for them? Because unfortunately, what we tend to see, as I mentioned, is that almost all drugs work really well, but all of them tend to wane in effectiveness over time. And it's not until you find the right combination of drugs and usually some type of therapy that people struggling with this see a remission of these really problematic symptoms. And this is something that is unfortunately a lifelong thing. So figuring out what the right intervention is, how to keep these people on it, how to pay for these types of things, is still an ongoing struggle. And hopefully, kind of from this information on schizophrenia and all the related things, you have a better sense of some of the different disorders that are out there and some of the different problems that people struggling with this disorder actually face. And with that being said, this kind of is going to mark the end of our lecture. Now, I know this was a lot faster than usual. I kind of rushed it a little bit. Also, I had some videos I was going to show that obviously we can't watch in this format. But this should be hopefully enough for you to get through the exam, get a sense of the different disorders that are out there, and really appreciate that there's a percentage of the population that struggles with stuff to a level that really makes their lives trying, and hopefully this can kind of make us a little bit more sensitive to some of the individuals that we might encounter along the way in our lives, and also just a little bit more knowledgeable about it. It doesn't mean that you're therapist now. I hope you understand that. And it doesn't mean that you have the ability to diagnose or treat anybody. But this can give you a good sense of what clinical psych's about, and also raise some awareness of these really specific topics, these sensitive topics that people are struggling with. And with that, I guess we're going to close out. I guess I'll see you all on Monday for our exam, and good luck in your studies in the process. Take care.